Functional Neurological Disorder, or FND, is a condition where a person experiences neurological symptoms when there is not any structural damage to the nervous system, but rather a change in how the nervous system is functioning or processing information. We use the term functional neurological disorder as evidence has shown that patients have found older terms such as conversion disorder or medically unexplained symptoms to be offensive and less helpful. There is a wide spectrum of symptoms that a patient may present with, sometimes concurrently. These symptoms can include loss of motor control. For example, they may present with functional weakness, sensory symptoms such as pain or numbness in specific areas. They also may present with speech problems, attacks or seizures, visual symptoms, and also cognitive problems. Although FNDs may present in many different ways, as already mentioned, there are still common associated symptoms which you may hear about in the patient history. For instance, anxiety, panic, and post-traumatic stress are commonly seen in FND patients. These should therefore be noted, however these are not causative of FND. The patient may also have a low mood or feel fatigued. Sleep problems such as insomnia or hypersomnia are also very common in FNDs. There are typical clinical signs of FND on examination which I will talk through in a second, but it's also important to look for patterns. For example, in functional weakness, the pattern of weakness will not be a typical pattern that you are likely to see in a stroke patient or patients with other neurological conditions. For example, they may not follow a particular myotome. Now, the signs to test for depend on a specific diagnosis. For functional weakness, for example, you may wish to use Hoover's sign. For some patients with functional weakness, hip extension will be weak on the affected side. However, if you test contralateral hip flexion against resistance, then hip extension on the affected side may improve and become strong, and this is termed Hoover's sign. There is also a sign called collapsing weakness. This is a tendency for an arm or leg to collapse when tested, and may be interpreted by a doctor as not trying. But in fact, patients with functional weakness typically find that the limb becomes weaker the more they try to move it. Another example is if a patient has a tremor in one arm. This tremor may be reduced or cease completely when they copy a clinician's movement with their other hand. There are many different signs that you can use on clinical examination, and we would urge you to visit neurosymptoms.org to learn more about these different signs. Rule out other disorders if necessary. Some neurological disorders present in a similar way in a similar subgroup of patients. For example, multiple sclerosis also occurs most commonly in women who present with neurological symptoms. It is also important to rule out mental health conditions or deficiencies such as B12, which may lead to similar presenting symptoms in a patient. In order to do this, a patient may undergo some blood tests, scans, or even an EEG to rule out epilepsy. So now let's talk about how we should communicate an FND diagnosis to a patient. Here is an overview of the key points that you should consider. Firstly, patients with FND, like with any other medical condition, need a clear, positive diagnosis, and you can make a real difference to this group of patients, mainly by how you interact with them. So show your patients that you believe them, actively listen to them, and help them to understand the diagnosis and signpost towards other useful resources that can help them process the information. It is very important to give the patient a clear name for what is wrong with them. For example, we can say, "I think you have a condition called Functional Neurological Disorder." It is surprising how difficult this seems to be for many clinicians to say, because many clinicians tend to begin their explanation by telling the patient what good news it is that they don't have a serious neurological disease. This can confuse patients. If we are making a diagnosis of multiple sclerosis, we don't start by telling them how fortunate it is that they have not had a stroke. Patients with FND come to see us because they are disabled and distressed by their symptoms. Being told that a doctor doesn't know what is wrong with them does not seem like good news to them. The patient deserves a clear diagnosis, and it's crucial to come out and say this right from the beginning. We can show patients the positive signs of clinical examination to explain how we make the diagnosis. FND has become the preferred diagnostic terminology as it has been shown to be least likely to offend patients as compared to other terms such as medically unexplained symptoms, psychosomatic, stress-related, hysterical, or pseudo. FND is no longer seen as a diagnosis of exclusion. We now see this condition as a positive diagnosis which can be made based on a typical pattern of clinical symptoms and signs, just as we would with any other disorder in neurology. Patients find that the concept of medically unexplained symptoms is very unsatisfactory, perhaps because it leaves open the possibility of a serious disorder that just hasn't been found yet. If you tell a patient that the diagnosis is one of exclusion, they will always wonder if one more test might uncover the real cause of their symptoms. Active listening is an important part of any consultation. So what is active listening? It's not just listening, but it's also taking active steps to let that person know that you are hearing them. It's about giving that person your full attention by showing them interest in what they're saying and giving them permission to express themselves, for example by asking them open questions. And it is also about reflecting back what you have just heard, to let that person know that you are listening and that you have understood their message. Doing this well will help the patient to feel listened to, believed, and allow them to have greater confidence in the diagnosis you make. For instance, patients appreciate a chance to mention all the symptoms that they have experienced. When it comes to prognosis, it's important to strike a balance between being hopeful but also being realistic about possible outcomes. Now let's see an example of how the diagnosis of FND is explained to a patient by Dr. Bieber Stanton, a consultant neurologist at KCH in SLAM.
So Karen, I think having met you today and listened to the story and examined you, I think you've got a condition called Functional Neurological Disorder. Is that something you've ever heard of? No, it's not very well known. So, well, the first thing to say is Functional Neurological Disorder is quite a difficult condition to understand. And I think because of that, there can be some misunderstandings about it. So I always start by saying to people and making it really clear that this is a real condition, okay? It's not in any way imagined or put on, and it doesn't mean that you're going crazy. But I know, unfortunately, some people might have the experience of getting that impression from other health professionals. But this is just as real as any other neurological disorder. It's just a bit different, really. And the difference is that in most neurological disorders, they're caused by some kind of damage to the brain or the nerves. Now in FND, there's no damage to the nervous system, but instead it's just a change in the way the brain is processing movement or processing sensation. And it kind of leads to a problem with the way your brain can access or control your body. But you know, it's absolutely just as real as any other condition. It can be very disabling, but it's something that we hope we'll be able to treat and get better. Maybe the other thing that people often ask me, of course, is what's caused it? And that's a difficult question to answer because it can be different from person to person. And in all honesty, we don't always fully understand the cause. But what we're starting to understand more is we're starting to learn more about what's going on in the brain in people with functional neurological disorder. So for instance, in the case of weakness, which you've got, we think it's a problem with the brain's attention system. And you might remember when we were examining your legs, and although you couldn't move your leg voluntarily, when we activated that same muscle through a different pathway, a more automatic pathway, it actually worked much better. And that's very typical of FND because it seems as though too much attention directed towards movement is actually interfering with normal, fluent, automatic movements. You can even see changes in brain scanning studies if you put people in an MRI scanner and get them to try to move. So it's complicated, I think, and it's difficult to understand, but we're starting to learn more and more about it and about how to get people better.
So here we have listed various resources to help you learn more about FNDs and to aid you in explaining them to patients. To learn about FNDs in more depth, please go to King's Health Partners and look at the FND course available. Neurosymptoms.org is also very useful, as is FND Action and FND Matters.